Welcome, everybody, to the NMOSD Master Class brought to you by the Patient Health Alliance. The Patient Health Alliance, or PHA, is a source of information and education for NMO spectrum disorder and related conditions. The content of the following presentation is based entirely on published data or expert opinion. PHA is not a clinical provider and does not offer diagnostic, therapeutic, or clinical care recommendations or advice on personal health. All patients and caregivers are advised to consult with their healthcare team for specific information. The overarching goals of the NMOSD Master Class series are to provide a practical update of the latest information on a specific topic with intention to illustrate key themes and clinical pearls. It's formatted to be inclusive of non-specialist audiences, and we have some time at the end for questions and answers to emphasize some of the key points. My name is Dean Wingerchuk. I'm a neurologist at Mayo Clinic in Scottsdale and Phoenix, Arizona. I'll be moderating today's session, and I serve as an advisor to the Patient Health Alliance. It's a real pleasure to introduce our featured speaker for today's event within the series, Dr. Jeff Bennett. Dr. Bennett is a professor of neurology and ophthalmology and the Gertrude Gilden Professor for Neurodegenerative Disease Research in these departments at the University of Colorado Anschutz Medical Campus. He directs basic, translational, and clinical research programs on NMO spectrum disorder, as well as other CNS inflammatory demyelinating diseases, and has specialty practices in neuro-ophthalmology and clinical neuroimmunology. He's recognized globally as a leader in understanding the role of B cells in these disorders, has elucidated key steps in the pathophysiology of several of these diseases, including NMOSD, and has contributed and participated in several pivotal clinical trials. Jeff, it's a real pleasure having you with us today on the topic of switching NMOSD DMTs, or disease-modifying therapies, focusing on clinical considerations.
Well, thank you, Dean, and thank you for the kind introduction. It's my pleasure to talk to the viewers about clinical situations impacting disease-modifying therapies in the treatment of neuromyelitis optica spectrum disease. Here are my disclosures. Neuromyelitis optica spectrum disease, as it will soon be redefined, is a recurrent inflammatory disorder marked by pathologic autoantibodies against the aquaporin-4 water channel. This subtle change in disease nomenclature, coming soon in the 2025 reclassification of the disease, is apt for this lecture, as all of our therapies are approved only for aquaporin-4 seropositive NMOSD patients. Neuromyelitis optica spectrum disease shows a classic pathognomonic histopathology demonstrating complement-mediated cytotoxicity, lymphocytic and neutrophilic infiltration, as well as astrocyte destruction and myelinolysis. As you are all aware, there are 4 therapies internationally approved for the treatment of neuromyelitis optica spectrum disease, and the anti-CD20 depleting therapy rituximab, which is approved in Japan, is often used off-label by many clinicians. While anti-C5 complement therapy, anti-CD19 B-cell depletion, and anti-IL-6 receptor blockade all have demonstrated high efficacy, as shown in this chart, in phase 3 randomized controlled trials and open label extension data, we realize that treating patients with NMOSD is not always a smooth process. Therefore, in this masterclass, I'm going to discuss reasons that may arise for considering switching or even discontinuing therapy in NMOSD, addressing strategies that you might consider when encountering similar situations in your patient care. First, let's examine the scenario of breakthrough attacks on therapy. This is my algorithm for NMOSD treatment, and one you can use as a basic schema for developing your own. Here we are looking at a situation of an NMOSD patient on off-label therapy or registered therapy who has a new attack and requires treatment change. So the first question that you must consider is whether a change in therapy is warranted. In this case, an African-American woman diagnosed with left optic neuritis and seropositive NMOSD was placed on anti-CD19 B-cell depleting therapy. She was treated with IV steroids and had a reasonable recovery in that eye. While on therapy, she experienced a new optic neuritis attack, treated with IV steroids and plasma exchange, and had reasonable recovery. So the key considerations I think that you have to consider in this situation is what is the timing of an attack from treatment initiation? What is the severity of that attack and recovery? And has the therapy been appropriately dosed, or is it showing lack of efficacy? For B-cell depleting therapies and interleukin-6 receptor blockade, we understand that more attacks in the phase 3 trial occurred early in the treatment period of the randomized control phase of the trial than later with continued therapy, and many of the patients who had attacks on therapy had lower severity of attacks and better recovery. Therefore, in this case, given the rapid onset of an attack after initiation of therapy on CD19 B-cell depleting therapy, we continued her inebilizumab, and she had no further attacks for the next 6 years. This is the data that I'm referring to with regard to the NMOMentum and SECURA trials for both inebilizumab and satralizumab respectively. Note on the waterfall plots on the left and right, the red dots represent relapses. In the green is the randomized control period for the NMOMentum trial, blue for the SECURA Sky and STAR trials, that patients who had attacks in that randomized control period rarely continued to have attacks in the open label period of the trials. As shown, 77% of the patients in NMOMentum and 85% of the patients in SECURA Sky and STAR had relatively attack-free periods after their initial attacks during the randomized control periods. And as shown in the bottom table, you can see that by 1 year into therapy, the attack rate had dropped significantly from the randomized control period, roughly by 50%, and continued to drop through 3 years of the NMOMentum trial. So what about breakthrough attacks that warrant changes in treatment? Does it always warrant a change in the mechanism of action of the treatment? In this case, we have a 28-year-old woman who had bilateral optic neuritis and transverse myelitis attacks that were initially treated as MS, who finally was noted to have NMOSD, and while on rituximab treatment, continued to have 4 relapses over 4 years, despite effective B-cell depletion noted in the blood. And as we look at these key considerations for therapy, we know that this timing of attack is not initially happening right after treatment initiation, and the severity of attacks might not be terribly severe at this point, although I haven't given you the details. The question is there alternative dosing, or in essence that B-cell depleting therapy might be improved in some conditions? And in this case, we switched the patient to inebilizumab because of some issues with her venous access and her general adverse nature to self-injection and her overall ability to self-inject due to residual neurologic function. And in this case, when we look at an example of switching patients who are on rituximab to inebilizumab, an alternative B-cell depleting therapy, we can note in the NMOMentum trial that all subjects who had failed prior rituximab continued to have a relapse course that was consistent with the rest of the treatment population. When we look at the biologic impetus behind the lack of necessity to change mechanism of action, we can look at a nice study performed by Sarosh Irani and colleagues looking at patients who relapsed on rituximab therapy for NMOSD, showing in the bottom panel that looking at cervical lymph node B cells and the antibodies they produce, that patients who failed therapy, shown by a star, failed to, even on rituximab therapy, as shown in the left bottom panel, continue to have imperfect B cell depletion in cervical lymph nodes with the continued production of aquaporin 4 autoantibodies. Similarly, inebilizumab, which drives B cell lysis through antibody-dependent cell-mediated cytotoxicity, may have improved effects in depleting lymph node-resident B cells. Here's a comparison of two anti-CD20 monoclonal antibodies, rituximab and obinutuzumab, which have distinct epitopes, showing that obinutuzumab, which acts predominantly through antibody-dependent cell-mediated cytotoxicity, or ADCC, has a stronger cell death induced by targeted Fc gamma receptor activation of NK cells and neutrophils. And when these two antibodies were used in a pre-dose renal transplant regimen, the obinutuzumab showed significant reduction in the amount of residual B cells in lymph nodes that were harvested from these patients compared to rituximab, while T cell depletion was not observed with either therapy, indicating better tissue potential penetration and lysis with an ADCC predominant antibody. Alternatively, surviving B cells in lymphoid tissue may escape depletion due to lowering their surface expression of CD20. And in this example, patients with immune thrombocytopenia who had failed B cell depleting therapy with rituximab had their B cells analyzed in the spleen upon splenectomy. And the population of B cells in these patients failing B cell depleting therapy showed low expression of CD20. And these B cells showed other markers of memory cell differentiation and could subsequently be depleted in vitro with anti-CD19 CAR T cells, showing you that sometimes switching therapies to a different marker for B cell depletion, 20 to 19, may hit those cells that are surviving despite B cell depletion therapies. So what to switch to when a change in mechanism of action is warranted? And in this case, I think all variations remain on the table. B cell depleting therapy to interleukin-6 receptor blockade, vice versa, as well as switching to anti-complement therapy or switching in any combination between those various therapeutic modalities. I think what the decision has to be based on is a case-by-case basis based on their prior treatments, comorbidities that might preclude treatment with certain entities such as hepatitis infection, tuberculosis infection, hepatitis requiring co-treatment for viral mitigation with treatment with anti-interleukin-6 receptor blockade or B-cell depleting therapy, and consideration of associated costs through pharmacy or medical coinsurance, transportation, self-administration abilities, and functional restrictions. When transitioning between therapies for attacks, I tend to overlap therapies immediately. When I'm dealing with a new attack, the patients are likely to be on high-dose oral prednisone, having received IV prednisone and possibly plasma exchange for the severity of their attack. And if so, when transitioning to a C5 inhibitor, I generally taper the steroids rapidly, considering the mechanism of onset of action rather abrupt for those treatments. But when transitioning to B-cell depleting therapies or interleukin-6 blockade, I tend to deliver a slower taper of therapies. And with regard to C5 inhibitors, I'll talk about vaccinations and antibiotic treatment a little bit later in this presentation. So, a special note on switching therapies due to access and not necessarily relapse activity. Some patients may be started on off-label therapies, particularly in the US, when insurance issues might prevent access to more expensive therapies, and in some countries where access may be limited in general to high-efficacy therapies that may be greater expense. In this instance, I think this chart shows you that when treatment is initiated with immunosuppressive therapies and off-label observational studies, there was a robust drop in attack rate noted before and after treatment. But these data must be tempered in the light that when you look at these numbers compared to the placebo group in our phase 3 high efficacy randomized control arms, you can see that the drop in relapse rate appears to be almost equivalent to what was observed with placebo in these trials. For that reason, you can look at our highly efficacious approved therapies and see that the attack rate in the open label extension of those trials is roughly 5 to 10-fold lower than observed with those immunosuppressive agents. And so for this reason, when I think about switching patients who might have been started on low efficacy therapy, I think that decision to switch, in my mind, is based solely on time, as in this case of a young Afro-American woman who had bilateral optic neuritis, was started on immunosuppressive therapy due to background hepatitis core antibody positive, who was stable on therapy for 1.5 years, but now had access to complement inhibitor therapies. So because she was on therapy for only 1.5 years, it's my estimate that it takes about 5 to 6 years of success on low efficacy therapy to be relatively sure that you're having the same robust, efficacious effect. And in this instance, we switched therapy to complement inhibitor therapies. So now let's look at switching therapeutics for treatment emergent adverse events, because treatment is always interrupted by several bumps in the road, so to speak. Treatment emergent adverse events may happen on initial treatment, and they may happen after switching therapies, or they may happen in addition to new therapies that are introduced because of other medical needs. So approaches include adjusting the medication or switching medications. And so let's look at some examples, and we're going to start first with infections and low IgG or hypogammaglobulinemia. So in this case, an NMOSD patient on long-standing rituximab treatment developed hypogammaglobulinemia with an IgG level of 305 milligrams per deciliter. My key considerations with hypogammaglobulinemia is first and foremost, what's the level of that serum IgG? In cases where the level is above 300 milligrams per deciliter, I continue to observe as long as there are other clinical circumstances involved, particularly infections. However, in this case, her IgG dropped to below 300 at 257 milligrams per deciliter. And for that reason, below that level, I tend to replace IVI with IVIG regardless of whether there's other clinical events. In this case, for the patient, she responded nicely to the IVIG, but subsequently developed some urinary tract infections, which cleared with antibiotics. But because of those infections, we obviously maintained her intravenous immunoglobulin therapy. And I always treat regardless of immunoglobulin levels with IVIG in patients who may not be below 300 milligrams per deciliter if they have bacterial infections. In this patient, she continued to have other infections, and for that reason, we switched her to satralizumab. So what's the data on B-cell depletion and hypogammaglobulinemia in NMOSD? When we compare the inebilizumab anti-CD19 data to long-term data on rituximab in other conditions that require B-cell depletion, we see that the majority of patients with either treatment do not get hypogammaglobulinemia, but inebilizumab may have a slightly faster decline rate with the same level of patients, that is less than 5%, developing severe hypogammaglobulinemia. And more importantly, when we look at the relationship between immunoglobulin levels and infection, there is no direct link. And even with patients with severe hypogammaglobulinemia, there wasn't necessarily an increased risk of severe infections. So, what about other treatment emergent adverse events? Let's take a look in this case about hepatotoxicity, leukopenia, and neutropenia. In this case, hepatotoxicity and neutropenia are very commonly observed with certain therapies. And when it comes to NMOSD, B-cell depleting therapy and interleukin-6 receptor blockade can cause liver enzyme elevation. And it's important in those instances to identify potential confounders and make medical adjustments, because many times patients are on other medications that may be causing liver enzyme elevations. For neutropenia, B-cell depleting therapies and interleukin-6 receptor blockade have both been associated with this treatment emergent adverse event. And treatment with G-CSF or GM-CSF for low absolute neutrophil counts may be indicated. And what we know from data so far is that although NMOSD shows elevated granulocyte activation markers in the cerebrospinal fluid, there is no clear evidence of disease exacerbation with treatment with either of these compounds. So the question is, can you rechallenge patients with neutropenia on either of these therapies? First, with interleukin-6 receptor blockade, neutropenia is often transient. I tend to retreat only after the absolute neutrophil count is restored to greater than 2,000 cells per millimeter, and I don't retreat if there's any absolute neutrophil count that's gone below 500 cells per millimeter, because interleukin-6 receptor blockade usually causes only a limited and transient neutropenia. B-cell depleting therapies, the risk of recurrence with rechallenging appears to be roughly in the 35% range and occurs within a year, so be careful if the decision is made to retreat. Here's a case of leukopenia. This is a 61-year-old Caucasian woman with NMOSD who had cervical myelopathy and tonic spasms. She was treated with inebilizumab, carbamazepine, and sulfamethoxazole trimethoprim for her steroid use. 1 month into treatment, she had leukopenia with a white blood cell count that had dropped to 1.3. Again, considering our first key considerations, identify potential causes of that drop in white blood cell count. Looking at her medications, we realized that carbamazepine and sulfamethoxazole could both be contributing. We discontinued her antibiotics and switched her carbamazepine to lacosamide. Her peripheral blood mononuclear cell levels returned to normal. Of course, 12 months later, she unfortunately developed another treatment emergent adverse event with hypogammaglobulinemia. Looking at those levels of 241 milligrams per deciliter, we started her on intravenous immunoglobulin, and she developed infections with pyelonephritis, prompting us to switch her to eculizumab with no further attacks for the next 6 years. So we switched this patient to eculizumab. What about vaccination and antibiotics with this switch to a C5 inhibitor therapy? We know that C5 inhibition has an increased risk of meningococcal and encapsulated organism infections, roughly 10,000-fold greater than the regular population. Meningococcal vaccination is required for patients receiving these therapies, both tetravalent vaccines and meningococcal B vaccines, which can be given separately or in combined doses, but should be restricted to those strategies once a patient has started with the same vendors for their various vaccines. Both dosages should be given 8 weeks apart for Men B and tetravalent, followed by a repeat meningococcal B vaccination 6 months to 1 year afterwards, and then every 2 years afterwards, with tetravalent vaccines being readministered every 5 years. I strongly recommend in appropriate individuals to have other encapsulated organism vaccinations such as Streptococcus and Haemophilus influenza. Also remember that vaccination requirements vary by institutions. These that I've given are in the United States as recommended by the CDC. For B-cell depleting therapies, when we think about meningococcal vaccination response, there's been a nice study done with ocrelizumab in MS patients showing that positive responses to vaccines for Streptococcus pneumonia, another experiential agent that we all experience through our life with potential exposures and infections, really had a somewhat modest reduction in vaccine response compared to a novel vaccine, keyhole limpet antigen in this study, or consider COVID a life example in terms of poor response to vaccination in patients on B-cell depleting therapies. Therefore, I'm not overly concerned with vaccine response if someone is on B-cell depleting therapy and gets their meningococcal vaccine, but in preparation, I tend, once a patient is diagnosed, to try to get them up on their vaccinations before beginning therapy for their NMOSD. When it comes to experience in clinical trials, looking at vaccine response in the ravulizumab trial for patients that had received prior rituximab treatment before vaccination against meningococcus, there were 2 patients that were noted in this trial to have meningococcal infections. One was not in the rituximab group to begin with, but for B-cell depleting therapies that had received a vaccination after therapy was initiated. One patient had a meningococcal B vaccination, and that was 1.5 years after initiating therapy, and this vaccination was administered just before she developed the meningococcal B infection that she had, suggesting perhaps that delayed vaccination was the main culprit, not her prior rituximab therapy. So special considerations for switching to C5 inhibitor therapy with antibiotics. I think it's important to consult with your infectious disease specialist regarding an antibiotic regimen. From my experience, if I am acutely initiating therapy following a relapse, I tend to use IV ceftriaxone initially to clear body stores and then follow up with a oral cephalosporin. If there's urgent transition prior to vaccination, I tend again to treat with IV ceftriaxone and then go to azithromycin. And if there's signs of meningitis, I often treat immediately at home with azithromycin, getting the patient to the hospital as soon as possible for administration of 3rd-generation cephalosporin. When considered transitioning for side effects or tolerance issues, I tend to minimize the overlap since there is no urgency necessarily in the transition. I tend to overlap at the next scheduled infusion, or if I'm switching from B-cell depleting therapy to C5 inhibitor therapy, dosing 2 weeks prior to the scheduled infusion in order to maximize vaccination response beforehand, and rituximab and inebilizumab switching to interleukin-6 inhibitor therapy. I tend to schedule the injections 1 month prior to infusion, so the patient has had their first 3 injections by the time they're discontinuing formally their frequent B-cell depleting therapy. So what about discontinuation? Are we ready really to discontinue therapy in some NMOSD patients? This, of course, has to be judged with caution. I'm giving you a single example here of a patient who was treated 3 years with rituximab. She had no history of relapses on medication, but had frequent sinus infections, so a treatment emergent adverse event, but her aquaporin 4 IgG serum titers had become negative. Repeated testing 6 months later continued to be negative. Our considerations included switching therapy due to her infections, assessing in the background her really negligible disability level, and what her relapse risk might be because of her aquaporin 4 IgG serum titer going negative. This patient with consultation decided to discontinue medication and monitor her serostatus every 6 months. 2 years later, she seroconverted back to aquaporin 4 IgG positive and returned to treating this time with satralizumab. Why we discuss potential discontinuation of therapy is the note that patients may serorevert on therapies. They tend to predominantly occur in this study from the Mayo Clinic and another from China on patients on B-cell depleting therapy and patients with low titers to begin with, younger age at onset of treatment, and higher efficacy therapy initiated sooner after diagnosis. And in the Chinese study, the relapse risk reduction with seroreversion was significantly lower at roughly the rate seen with some medical therapies for NMOSD. For this reason, we had decided to watch her serostatus closely and to allow her to remain off therapy for some period of time. If a patient can't be monitored for seroconversion, then I don't think this is a wise strategy to use at any time. And still, there may be risks as people have been described to relapse even without their serostatus reconverting. So in general, I've discussed switching therapies in NMOSD, which as you can see is part science and part art. We have 4 approved therapies, and we have unapproved oral immunosuppressants and biosimilars, including rituximab and its use as an alternative B-cell depleting therapy. Switching for relapse really needs to consider the duration of treatment, mechanisms of action, vaccination status, and if can be monitored, the efficacy of that therapy which has been initiated. For adverse events, is it treatment related? Is it due to concurrent medications? And can the administration be adjusted in order to help those adverse events? Does an additional co-medication such as IVIG need to be started? And are clinical aspects of the treatment-related adverse events responding to that therapy? Finally, aquaporin 4 IgG serostatus may get into our treatment regimen as a consideration for continuing or even discontinuing treatment and what sorts of treatments might be considered down in the long run. So I appreciate everyone's attention and hope that this has been informative and the question and answer session can provide additional helpful information. Thank you.
Jeff, thank you very much for an outstanding and very comprehensive discussion in a relatively short period of time. This is a complex topic, and I think you've shared a number of considerations and pearls based on both your experience and on evidence that will help clinicians. A few questions to pose to you to maybe expand on some of the topics and themes. The first one, do you have any particular preference when sequencing therapies when a patient has relapsed on a drug?
Well, I think that's always a tough consideration when it appears almost that it's a grab bag in terms of trying to decide on a patient's initial therapy to begin with if there are other strong considerations or contraindications to treatment. I often base it first on the severity of the attack. And NMO can be devastating, and attacks aren't always mild on treatment, unfortunately. And when there's a severe attack that's happened, I often gravitate to C5 inhibitor therapy for patients that may have, unfortunately, not much neurologic function left to preserve if there's been a severe attack, whether it's in vision or whether it's in other neurologic function based on spinal cord injury. For B-cell depleting therapies, I tend to move with more severe attacks outside of treatment to C5 inhibitor therapy. For moderate attacks and breakthrough, I tend to move towards interleukin-6 receptor blockade, especially with observational studies showing efficacy in patients with this type of therapy on B-cell depleting therapy who are breaking through. But I don't think there's a strong justification for any particular choice, but obviously discussion with the patient on administration, other aspects of therapy and cost all have to be considered.
Yeah, very good. If a patient has a relapse, how long do you think you would allow a patient to remain on therapy, and what are the factors that play into that decision?
Yeah, I mean, how patient to be. As I said, the first consideration to make is maybe therapeutic decision making in NMOSD is not one and done like we used to consider before we had phase 3 clinical trials, that patients with an early relapse on therapy is sometimes warranted because clinical trials have shown, at least for interleukin-6 receptor blockade and B-cell depleting therapy with anti-CD19, that patients with early relapses tend to respond later on without further relapses. And I usually use, based on that chart for the N Momentum trial, that if a patient has gone more than 18 months into therapy, so 3 infusions, I tend to be quite concerned if they've had more than 1 relapse. I tend to take them off. If it's after 2 years, even 1 relapse, I tend to not have patients anymore. But that's my interpretation of the data, suggesting that if they're breaking through that late into disease, they're likely not having a good penetration for B-cell depleting therapy into lymphoid tissue and for interleukin-6 blockade. Maybe they're not having appropriate modification of T-cell differentiation, or in terms of B-cell maturation, which that drug can affect as well. Again, not having appropriate suppression. For IL-6 receptor blockade, I tend to check acute phase reactants in patients. If they're become elevated, I know that they're not responding as well as I would think to this medication, which drops those reactants very quickly as you check a patient. Not that it's related to therapeutic efficacy per se. And for B-cell depleting therapy, obviously I'm checking levels of B cells in peripheral circulation. As noted in the N Momentum trial, patients after 1 infusion that have 5 or greater B cells at the time of reinfusion tended to have a slower response to therapy. Finally, for C5 inhibitor therapy, I've rarely seen a patient under my care have a breakthrough treatment, but certainly I would check for a resistance, which is seen in some Asian patients, as well as the possibility that there is residual complement C5 function, as could be quickly checked with a CH50 test.
Yeah, thank you very much. It's complex, and the clinical trials and open label observations over the last several years have really added some important information, but raised a lot of new questions. We look forward, I think, to biomarker signatures that help us predict relapse risk with more precision. If we think about switching drugs for the treatment emergent adverse effects that you were describing earlier, what are the lead considerations for you that make you take action?
I think when it comes to infections and hypogammaglobulinemia, my first approach is there active bacterial infections, and how comfortable do I feel, as given in the two examples, about switching to alternative interleukin-6 blockade with active infections going on, or complement inhibitor therapy with active infections going on. And with encapsulated organism risk being higher with complement therapy, I tend to shy towards treating with interleukin-6 receptor blockade, just because of that additional risk. But it's not absolute, as shown in the one patient who had significant deficits that we switched to complement inhibitor therapy despite her active infections. In my experience, it's interesting that for interleukin-6 receptor blockade, while I often see patients have no further infectious problems, interestingly, their hypogammaglobulinemia never really resolves on its own once they've achieved this status of hypogammaglobulinemia. So sometimes IVIG has to be maintained based on the level, but other times I'm able to stop it. It just doesn't get back to normal levels. So all of those have to be, in your consideration at the time, the patient's antibiotic and vaccination status as well.
Yeah, excellent. Finally, you talked a little bit about vaccinations throughout the presentation. Wondering if you could expand on that topic a little bit about how you think about vaccinations and timing of vaccinations, especially thinking ahead, not just the therapy you're selecting now, but what potential contingencies there may be, or mitigating strategies there might be should things not go well for a patient and they relapse on the first therapy you're putting them on.
Yeah, I think you're bringing up an important consideration as we think about the long road of NMOSD treatment. We understand that we're treating patients with immunomodulatory agents, immunosuppressive agents, and while we can note that infections with encapsulated organisms are significantly elevated in risk with complement inhibitor therapy, other therapies can be complicated by infections that it would be best for the patient to have their optimal immune status. So at the beginning of therapy, I tried to get patients vaccinated and up to their age-appropriate vaccine norms when it comes to varicella-zoster vaccination, because B-cell depleting therapies increase the risk of zoster reactivation. I make sure that patients, if age-appropriate, have their pneumococcal vaccinations. And because of the possibility, even if they aren't selecting C5 inhibitor therapy at the onset, may need to transition it to that therapy for one reason or another, I make sure that they can get started on their meningococcal vaccination before they might choose some alternative therapy that might slightly lessen vaccine response, as I talked about, particularly B-cell depleting therapy. So I tend to like to get that vaccination series started about 4 to 6 weeks prior to the initiation of B-cell depleting therapy, if that's the route that's chosen, and subsequent vaccinations, I tend to get at least 6 weeks after the last infusion of B-cell depleting therapy, if it's the next 8-week infusion vaccination that's needed, or subsequent vaccinations that are necessary somewhere before, at least 1 month before the next round of infusion, so you're not destroying your vaccine responsive B cells once you've administered the vaccine. So I tend to want to think ahead if possible. We all inherit patients who may not have been vaccinated, and discussions with them about the role of vaccines for both treatment emergent adverse events and potentially switching therapy is an important discussion to have, because if you need to rapidly transition, a patient that's already vaccinated allows you to do so without any additional need for antibiotic coverage with a C5 inhibitor therapy.
Yeah, excellent. Thank you very much for expanding on these topics in the Q&A session. And we'll bring this part of the program, or this program, to a close. At this point, I want to, on behalf of all of the viewers of this chapter in the master class, Jeff, thank you very much for your time and sharing your expertise on what is a really complex topic. We've come a long way in advancing therapy for these patients with NMOSD seropositive. But as you say, it's a long road of treatment, and there's still a lot of factors we need to take into account when trying to optimize their health and their outcomes. So truly appreciate you sharing your thoughts with us today.
My pleasure. Thank you.
I'll remind our viewers that the NMO Master Class has several chapters or episodes that are available on the Patient Health Alliance website. You see the link in the QR code below. There you can see the featured speakers, the timing of the educational events, and the presentations and associated media associated with each of the presentations. Finally, the NMOSD Master Class is sponsored by an educational grant from Alexion AstraZeneca Rare Disease. And we're very grateful for the support that they've provided for this very informative set of conversations with the NMOSD community.